Afternoon. It's my pleasure to introduce Dr. Corey Keller, who is here visiting us from Stanford. Dr. Keller is finishing up his residency in psychiatry. He's a postdoctoral research fellow in neuroscience at Stanford and received his MD and PhD in neuroscience from Albert Einstein in New York. His work is really timely, particularly for the Department of Psychiatry, as we're really interested in looking at emerging therapies, novel therapeutic interventions, particularly in the area of mood disorder. So there's a great resurgence and interest in developing these new therapies that can be precision-based and really provide very focused therapies for people, in particular those individuals who've not responded well to traditional interventions such as pharmacotherapy. And so this is a work of great interest. And today we're excited because Dr. Keller's work is really looking at brain-based biomarkers that can be used to predict non-responders to one particular intervention type, and that's transcranial magnetic stimulation. And so this has got great promise in the field. So I'll turn it over to Dr. Keller, and again, thank you all for being here this afternoon. Thanks.
Thank you, Dr. Perry, and for the opportunity to speak today. My name's Corey. I'm a resident and postdoc at Stanford, as Dr. Perry told you about. I'd like to tell you a little bit about personalizing brain stimulation for neuropsychiatric disorders. I'll first briefly introduce brain stimulation and TMS, talk about some of the work that I've done at Stanford, and then talk about some of the future work that I hope to do. So as we all know, depression is one of the leading causes of disability worldwide. It affects over 350 million people in this world. We lose over 1 million people every year to suicide. Current pharmaco and psychotherapy are adequate for some and not for others. Still leaves over 5 million people in the US treatment resistant that need better approaches. So enter interventional psychiatry, or the use of focal neuromodulation to selectively alter circuits and alleviate disease. Our current tool is transcranial magnetic stimulation, or TMS. It's an electromagnet that induces a time-varying magnetic field, penetrates through the skull, induces an electrical current, and can modulate brain activity. We know that a single pulse of TMS, when applied to the primary cortex, within 5 milliseconds can elicit action potentials in both excitatory and inhibitory neurons. We also know that when you apply TMS to the motor cortex through the corticospinal tract, you can get a motor evoked potential. So this is how TMS is used in the clinic. We call it RTMS, or repetitive TMS. It's basically you apply it 10 times a second for 2 to 5 seconds, and that's a stimulation train. You have a resting period, and that resting period is between 10 and 26 seconds, depending on the stimulator. And you apply that over and over and over again for about 3,000 pulses every single day for about 4 to 6 weeks. The treatment target is the dorsolateral prefrontal cortex. TMS has been used in depression for over 10 years, and we know there's clinical efficacy across multiple randomized clinical trials. The response rate is about 25 to 50% right now. What we don't have is a mechanistic understanding of TMS, a neuromarker to stratify, predict, and track treatment outcome, and the ability to selectively manipulate this neuromarker. TMS is based on the idea of long-term potentiation and depression in animals, which has a robust literature. Basically, electrical stimulation is applied at usually 100 hertz stimulation to the hippocampus to elicit long-term changes in excitability. Now, in humans, we can't do 100 hertz stimulation because we would induce a seizure. So people turn down that frequency and use between 5 and 20 hertz. They first applied it to motor cortex because you can look at the motor evoked potential. And they showed sometimes that 5 hertz stimulation to the motor cortex elicits an increase in the motor evoked potential, so may increase excitability. But when you look at other papers, and especially look at the 10 hertz frequency that we use for treatment of depression, there's actually not a clear effect. In more current, more recent protocols, Theta Burst stimulation, when you look across a number of subjects, there's really not a consistent effect in the motor evoked potential. So when we thought we'd have a consistent effect in the motor cortex when we applied this high-frequency TMS, it's not super clear. And outside of the motor cortex, when we're trying to hit regions that are involved in emotion and mood, it's even less clear because we have no clear way to measure these changes. So this is what we think we're doing. We think that in depression, there's a hypoactive dorsolateral, no, that's not going to work.
Corey, can I ask questions?
Please, sure.
Can you just explain Theta Burst quickly because versus the usual TMS?
Yeah, so your normal RTMS is 5 hertz, 10 hertz, 20 hertz for that train, and then there's a rest period. Theta Burst is Theta Burst is essentially, it's every 200 milliseconds, you have a burst at 50 hertz. I believe it's usually 3 pulses, and those pulses are every 200 milliseconds in theta fashion. And you get basically the same number of pulses in about a 3-minute treatment that 10 hertz has normally in a 40-minute treatment. So it's a different type of protocol that is being applied. So we think in depression we have decreased activity in the dorsolateral prefrontal cortex, and that weakens the central executive frontoparietal network. That lack of inhibition between the default mode network causes an increased activity in the default mode network and may contribute to some of the ruminations and symptoms that we see in depression. We think RTMS, when applied locally to the dorsolateral prefrontal cortex, will increase this activity, strengthen the frontoparietal network, and normalize the default mode network. There's some neuroimaging that suggests this, but for the most part, we're not quite sure. We also lack the ability to selectively manipulate circuits and measure the outcome of those circuits. And I'll touch base on this later, but if we had a tool that we knew which pattern strengthened that circuit and we could measure the output and also weaken that circuit, we would really have a tool that would have almost unlimited treatment applications. For psychiatry, we know depression is FDA approved for the past 10 years. OCD was approved last month, and there's phase 3 trials for both PTSD and substance use. There's also a lot of interest in neurological disorders. So 5 to 10 years from now, TMS may be a treatment that is FDA approved for most of these disorders using the same exact dorsolateral prefrontal cortex 10 hertz stimulation in an open loop type fashion. So we need better tools to measure, to optimize, to personalize. So this is what I think TMS is doing. That left prefrontal 10 hertz RTMS elicits action potentials that induces excitability changes in the frontoparietal network. And the strength, duration, and specificity of those changes determines clinical outcome. The way I try to ask these questions is threefold. First, I think we need to really look under the hood. And so we have an intracranial model where we have very high spatial and temporal resolution of our recordings, and we know exactly where we're stimulating. And I use that as a tool to try to understand the mechanism underlying how repetitive stimulation induces plasticity. We then have taken these tools outside the skull and try to combine simultaneous TMS with EEG to be able to measure these tools and bring them into the clinic. And finally, can we scale this up into a large-scale multi-site biomarker monitoring system? So I got my PhD in invasive neurophysiology, where patients with medically intractable epilepsy would come into the clinic. My neurosurgeon boss would perform a craniotomy and implant these grade and strip electrodes on the surface of the cortex subdurally. Implant up to 300 electrodes. And during that time, while the patient is waiting to seize, essentially, so we can localize the seizure cortex, we can obtain recordings from the awake human brain with really high spatial and temporal resolution. You can localize these electrodes by comparing the preoperative MRI with the postoperative CT and get these beautiful brains. One thing we lack in human neuroscience is the ability to causally perturb and measure those changes. So most human neuroscience, resting fMRI, resting EEG, even ECOG, is by looking at measures of association over time. So how correlated are two regions of the brain? We don't have a way to perturb and measure it like most animal neuroscience is performed. So we co-developed a tool called corticocortical evoked potential mapping, which is actually pretty simple. We basically apply focal electrical stimulation to the surface of the cortex through these intracranial electrodes and measure the evoked potential at every other region of the brain. The waveforms are quite complex, but in general we see these two deflections, one early within about 20 milliseconds that we think reflects a polysynaptic early excitation, and a later, most likely GABAergic slow wave. So we have a tool to causally map out directionally these corticocortical evoked potentials, corticocortical networks. I'm not going to dive into too much detail, but there's a lot of applications of this tool. The first question we asked is, we have these large-scale resting fMRI networks, regions that are correlated in the bold signal over time, but we don't know the underlying neural basis of those regions. And so we basically took these epilepsy patients, looked at their resting fMRI before they came in and put electrodes in, and we essentially looked at regions that were positively correlated, gave a single pulse to one site, and measured the evoked potential at the other site, and vice versa. And the quick story here is that regions that were positively correlated with the bold signal showed a strong corticocortical evoked potentials. There's some pathway that may generate these positive bold correlations. The negative bold correlations, or the blue regions, if you're interested, were much more complex. We can stimulate many different regions of the brain and use graph theory to just ask, where are the hubs of the brain? Where are the projectors and the integrators of the brain? And lastly, we can use this single pulse tool to perturb specific brain regions and specific timing to understand how necessary a brain region is in performing a specific task. So this was just a visual processing task where we either stimulated the fusiform face area or the parahippocampal place area when a patient was looking at a visual stimulus, and we could give that single pulse either before the stimulus, during, or after. And we could measure its effect on behavior and electrophysiology. Now, after developing this tool, I got interested in psychiatry, interested in brain stimulation, and wanted to understand how our TMS affected the brain. And I realized that ECOG, this approach, this intracranial approach, allows us to know exactly where we're stimulating and know exactly where we're recording. Whereas TMS, we don't really know where the current is going in the brain, and we don't have any great tools to measure where the current's coming from in the brain. And so we use this as a model to understand the mechanism underlying how repetitive stimulation induces long-term changes. So this is just one patient, and you can see where the electrodes are in the brain. We electrically stimulated the left prefrontal cortex and measured everywhere else. This was our schematic here. So the single pulses are our corticocortical evoked potential, where we applied single pulses, measured the excitability at baseline. We then applied this 10 Hertz stimulation in a very similar fashion as you do repetitive TMS. So 3,000 pulses for about 12 minutes. And then we asked, how do those corticocortical evoked potentials change after this 1 day of treatment? This is an example of our corticocortical evoked potentials. You can just see the strong response within 20 milliseconds after giving a single pulse. Very clear, very clean signals. This was our CCEP map at baseline, so basically our excitability map. We applied a single pulse to the prefrontal cortex, and you can see strong responses locally and also distally here. We think this is our frontoparietal network that we're basically probing. So 20 milliseconds after we give a single pulse, we can see that in the posterior region. This is before any repetitive stimulation is applied. So if we just focus on one region here, we can record these changes across the 300 electrodes that we have, and just ask what happens after the 10 Hertz stimulation. We see something like this. So after this 10 Hertz stimulation, we see a suppression in the evoked potential that basically rebounds back after about 10 or 15 minutes. So 10 minutes of stimulation induces about 10 to 15 minutes of changes. The next thing we did is we asked, where are these changes, right? Can we predict them based on the network that we're stimulating? And the story there is essentially using a combination of the baseline single pulse evoked potential, so how strong is that response at each region, and also the distance from the stimulation site. We could predict with really high accuracy where these changes were going to occur. Okay? You can imagine this has some clinical implications if this was true for TMS. If we knew where we were going to change before actually changing it, we could move that stimulation site around and find the right network that we wanted to hit. The other cool thing about this study was that we could actually look within the 10 hertz stimulation, and we can look at the evoked potential at each pulse. And we can essentially quantify the plasticity induction phase, which is something that is not typically done either in animals or in humans. So we could actually monitor, potentially in real time, how this brain is changing. So the questions that arose here are, can we monitor these signals non-invasively? Non-invasively, can we predict which regions are going to undergo plasticity? And can we start to develop more individualized, personalized treatments? So I hope to have shown you so far that direct electrical stimulation paired with this intracranial EEG represents this nice model that sort of links your animal plasticity studies to your human neuroimaging studies. And showing that 10 minutes of repetitive stimulation induces about 10 to 20 minutes of predictable changes in brain function. Okay, so now can we bring this outside the skull in a noisier environment, but in using a tool that is much more generalizable to other clinical populations, that we could actually bring this into the clinic? Can we see the signals that we saw intracranially? So this is TMS and EEG. It's actually been around for a little while, but the ability to perturb a region with TMS and measure with really high millisecond resolution with EEG has a lot of appeal. EEG is relatively cheap. It costs between 20 and 50 grand, but it's a one-time purchase as opposed to something like neuroimaging and MRI where you have to pay per hour, and you can get this into the clinic. This is the problem with TMS EEG, is this is what the signals look like when you give a single pulse and you try to measure the evoked potential. You don't see much, right? There's tons of artifact associated with the TMS. The TMS actually usually saturates the amplifier. There's pressure against the electrodes, which causes artifact. The TMS pulse, if you've ever gotten TMS, your eye usually twitches, your jaw sometimes twitches. It activates certain muscles, which cause a lot of EEG artifact. So we have a lot of cleaning to do before we get to something like intracranially, where we saw really clean signals. That was basically the first year of my residency, working in close collaboration with Wei Wu, who's the postdoc in the lab, to try to clean these signals. There was a semi-automated method that we essentially took it one step further and made an automated method. It's a three-step process. One just essentially removes the large amplitude artifacts by interpolation. Then you go through and remove bad epochs and bad channels. And finally, based on a spatiotemporal template matching, you can remove common EEG artifacts like eye blinks, EOG, EKG. And the bottom line is you end up with this TMS evoked potential, or what we call TEP. So time zero is when the TMS pulse is applied. Each blue channel is one EEG electrode. So what you see here is this multiphasic waveform that starts at about 10 milliseconds after the pulse and lasts about 300 milliseconds. Each of these peaks have its own spatial pattern of activation, and each of these peaks, we're starting to uncover the neurotransmitters that are active during that time period. It's complex, but when you source localize these changes, you get these sorts of maps. It's maps of causal brain dynamics measured non-invasively and something that we can actually take into the clinic. I think this is one of the first times in human neuroscience that we have a causal brain mapping tool that we can bring into the clinic, which I think is kind of cool. So lots still to be done here. The first step we did is we looked at the test-retest reliability of these signals and showed that across days, most of these potentials are actually quite reliable, which will be important in terms of longitudinal monitoring. The next step we had is we asked, what is the site specificity of these TMS evoked potentials? What happens when you ping different regions of the brain? Do the TMS evoked potentials differ at all? This is just some preliminary data I'm showing you from 2 sites, but we enrolled healthy controls and gave single pulse TMS to either motor cortex or visual cortex, and just asked, how do the TMS evoked potentials differ? So what I'm showing you here, it's a little complicated, but it's a contrast map of these 2 sites. So this is 10 to 50 milliseconds after the single pulse. You can see regions in blue are those where the visual evoked potential was stronger than the motor evoked potential, and vice versa for the red. So to break that down a little bit, if we look at responses close to the motor cortex, what you can see is when you pinged the motor cortex, you got a stronger evoked response than when you pinged visual cortex, and vice versa for regions close to the visual sites. So there's some level of site specificity here within the first 150 milliseconds of this TMS evoked potential. Now these regions are pretty far apart, right? In these subjects, we actually pinged 26 different sites in the brain. So one of our questions will be, as we walk closer anatomically, do we still see any sort of site specificity in the TMS evoked potentials? And what components are site specific? Is it the one 10 milliseconds after the pulse? Is it the 150 or 200 milliseconds? So that's very much a works in progress. But I hope to have shown you that TMS paired with EEG allows for the causal mapping of brain circuits in humans with high temporal resolution, that there's some site specificity within 150 milliseconds of these pulses, and that there's a lot more to be done. Now, how does this relate to depression? So we recently completed a randomized, sham-controlled, double-blind study in which we enrolled patients with major depressive disorder and randomized them to real or sham RTMS daily for 4 weeks. Basically, your normal clinical treatment. And all we asked is we measured these TEPs before and after those 20 days and just asked, where are the brain changes? How specific are those changes to treatment arm, and do they relate to clinical outcome? This is our stimulation site and what our TEPs look like. It's worth noting that all of these analysis that we did on all 4 TEP evoked potentials, the different components, and corrected for multiple comparisons, but the only changes that we saw in the group by time effect was in the P30. So 30 milliseconds after a single pulse of TMS, we saw this effect in group by time. This is our main effect here. So in group being active versus sham stimulation, and time pre versus post treatment, we saw an effect here in this left frontal and posterior region. Again, this is all in the P30. And if you break this down, you basically see this effect is driven by the active RTMS arm. So when you look at pre versus post RTMS in the active arm, there's a change in the P30 that's not there in the sham RTMS arm.
How does the sham look like here?
How does it look? Oh, how do we do the sham? So we use that double coil, basically flip it, so no TMS is actually getting into it. It's blocked. And we put electrodes right under the TMS coil and stimulate at 10 hertz to make it seem like, the scalp sensation is there. What we saw here in this P30 is that the P30 actually gets suppressed in the active RTMS arm and not the sham arm. And finally, the degree of P30 suppression seemed to predict clinical outcome. So patients that had more P30 suppression seemed to get better. A couple points on this. We also gave single pulses to other regions in the brain. So we gave the single pulse to the treatment site before and after, but we also gave it to visual cortex and to motor cortex. And we didn't see any changes like this when we pinged visual or motor cortex. The other interesting thing is that this P30 is the same signal that we saw intracranially, that the 30 millisecond potential is what changed after that 10 hertz electrical stimulation. The P30, we think, is the beginning of our GABAergic wave. We think the first 10 to 20 milliseconds or so is excitatory and glutamatergic, but at some point there's this long wave we think is all essentially GABAergic. It's the brain responding in this inhibitory way. If that's true, and we're suppressing this P30, we may actually be decreasing the amount of inhibition. It's actually quite consistent with the animal literature that is starting to show that RTMS doesn't induce your normal long-term potentiation like you would think in animals, but is actually maybe decreasing your amount of GABAergic drive. Again, that's a little hand waving there, but it's an interesting thought. So what's the problem with this study? As you can see, the ends are quite small, right? 20 or 15 patients in each arm isn't that much. Pretty strict inclusion-exclusion criteria. These patients were also medication naive at the time of treatment. So how this relates to your normal patient walking into the TMS clinic is not clear to me, at least. So that's what we're working on right now, is we're trying to scale this up. This is a naturalistic biomarker monitoring study where essentially patients enrolled in 6 different centers around the country that come in and are getting RTMS treatment as covered by insurance. We essentially stick an EEG cap on them, and we can measure EEG changes as often as possible, either once a week or every other week, depending on the patient preference. And we just measure changes before, during, and after using this TEP approach, not changing the treatment at all. And the bottom line is every week we can get a measure of how much their brain changed on that day. We can compare that week by week and try to relate that to the various clinical symptoms, the type of stimulator used. There's 10 hertz treatment, there's 1 hertz treatment, there's Theta Burst. In the clinic, there's these large varieties of different ways that treatment is being done. This is just one example of what a TEP looks like in one patient before and after treatment. This is sort of just a highlight. You can imagine the amount of data in a single patient. If we do longitudinal monitoring weekly, we have 6 weeks of measurements. We have pre and post treatment each week. And for each condition, we have 500 milliseconds of data. So statistically, this is something that we're currently trying to work out, but it's a lot of data. I think it's better than a small amount of data, but it's not a simple question. I'm going to give you just 2 examples here without any statistics, just to sort of pique your interest, hopefully. So this is a 69-year-old patient who came in that got brain sway treatment, which was 18 hertz stimulation. You can see the treatment attributes up there. This is treatment number 2. You can see the intertrain interval, the number of pulses used on that day. We record basically everything that the clinician does. In the brains, you are seeing an effect size map. So for this day, how much their brain changed in this time window of the TEP. So 40 to 70 milliseconds in the TEP, red regions show that the TEP went up, blue regions show that it went down. It's not that important right now, but it's basically saying that we can see changes. We can see changes across the whole TEP. This is week 1. You can look at week 2, week 3, week 4, and the whole treatment. What's cool is you can also look at the clinical symptoms. So we get self-report scales for depression, anxiety, and quality of life. What's worthwhile to point out here is you can see the number of pulses up here. The clinician wanted to fit more in, so they actually doubled the dose between treatment 3 and treatment 4, and they did that by decreasing the intertrain interval. And at some point, this patient actually got worse. His anxiety went up, his depression didn't get better. And if you contrast that with someone who remitted after just 3 weeks of treatment, our goal is essentially trying to figure out on a large scale what this person's brain was doing that got better versus someone that didn't. So I hope to have shown you that daily RTMS induces in this randomized clinical trial with a relatively small n, induces this P30 suppression that's there in the frontal and parietal regions and is there in the active and not the sham arm, and that the change seems to predict clinical outcome. We're trying to replicate this biomarker in a naturalistic setting right now. And then phase 3 would be a randomized EEG-informed closed-loop treatment to maximize that biomarker. So I'd like to shift gears a little bit and talk about future directions. I'm calling this the Personalized Neurotherapeutics Lab because I think it sort of says what I want to do. This is my goal, is that to understand the fundamental principles of human brain plasticity and build transdiagnostic real-time monitoring platforms for personalized neurotherapeutics. I'll use these two different approaches that I described, the intracranial approach, where we know exactly where we're stimulating, we know exactly where we're recording with really high signal-to-noise ratio, bounce that back and forth with outside the brain in something that is clinic-ready and generalizable. And I'd like to point out and hope that I have close collaboration with animal folk who really want to do translatable research using the frequencies and the patterns that we actually have available in the clinic, but ask the questions on a much more mechanistic basis. What cell types actually respond? How do we manipulate these in other ways? And we started to do this. I've been working with Carl Deiseroth and people doing calcium imaging and multiple simultaneous recordings, changing frequency, intratrain interval, and those things that we could actually bounce up to ECOG very quickly and then even to TMS EEG. The 3 different projects I'd like to work on is, one is this idea of metaplasticity and its role in RTMS, and this is a K23 that will start next July. Quantifying this plasticity induction phase, which is a paper that we're currently writing up that I'll explain a little bit more, and then this personalized brain stimulation that I just submitted a DP5 Early Independence Award last week actually. And I'll just touch base on each of these a little bit. So metaplasticity is this really cool idea, and it's been in the animal literature for a while. It's basically called the plasticity of synaptic plasticity. It's this idea that previously induced plasticity can essentially influence the synapse's ability to induce future plasticity. So if you take your normal experiment with high or low frequency stimulation, you apply that and it causes some change for some time. Metaplasticity is essentially something that you do before that experiment that then influences that outcome. Priming, something actually we do in the clinic sometimes. People use right-sided 1 Hz stimulation before they do left-sided 10 Hz, is an example of metaplasticity. But you can imagine how this has clinical implications. We're doing daily treatment in the clinic, and you can't imagine that one day's treatment isn't going to affect the next day's. And so how those build and how they relate to clinical outcome is something that we can quantify and we can ask. So do these daily changes build because of this metaplastic effect? And there are actually really well worked out computational models that we can ask, does RTMS work in this way that the computational model suggests that they will? So this is a normal 4-week schematic of RTMS treatment, basically daily for 5 days for 4 weeks. We're going to enroll patients, randomize them to active versus real RTMS, and just apply treatment as standard of care. But we're going to record every single day how much their brain changes. So we can quantify how much their brain changes every day, and then what that cumulative effect is. And we can start to relate these 3 different measures: how much the brain changes every day, how much the brain is changing cumulatively, and then what the clinical symptoms do. And we sort of have a hypothesis that we think the single session effects will decrease over time. We think the cumulative effect will increase but also saturate, and then at some point the clinical symptoms will improve. So the relationship between those 3 measures will actually tell us a lot about how RTMS is really working. One more note on this. So there's this computational model of metaplasticity that has been well validated both in vitro and in vivo in animals that essentially says there's a sigmoidal relationship between the pre-stimulation calcium concentration in an individual area and how much long-term potentiation or depression it will affect. So the more calcium that you have in that area, the more likely that you're going to get LTP, and the less calcium, the more likely you're going to get LTD. there's this threshold potential, that is that calcium concentration that will shift it. You can actually change this threshold potential. So there are certain experimental manipulations that you can shift it such that the same calcium concentration that caused LTP actually caused LTD after that shift occurred. And there's been some suggestion that maybe RTMS works in this way. And so that's essentially what we're asking is, instead of pre-stimulation calcium concentration, we're measuring pre-session TEP as a measure of excitability, and then how much the TEP changes. So every day we can plot essentially what the relationship is between the pre-session excitability and the change, and ask, is it a linear effect? Is it sigmoidal like we would suggest? And then is there a point in RTMS treatment that actually may shift this curve? Because clinically, if we knew that that curve was going to shift, and we knew that that 10 hertz stimulation would actually induce the opposite effect that we would expect, maybe we would stop treatment, maybe we would change our treatment to actually keep it on that curve. But the bottom line is we can test this. So this plasticity induction question that I alluded to a little bit, I'm just going to give you one example of some cool findings that we have that we think is interesting. So this is an ECOG patient that came in, intracranial EEG and epilepsy. We applied our electrical stimulation, and we're measuring in the yellow region, pretty close to the stimulation site. When you apply 5 seconds of 10 hertz stimulation, and you just look at that single channel in a single trial, you see this effect. You actually see a decrease in the voltage over time. You see this off response, and there's actually an evoked potential to every one of these 50 pulses. What's cool is when you apply these trains repetitively, like you do for RTMS, you see this shift where what started going down initially actually becomes a positive deflection, and that the off response actually gets clearer too. Another way of showing that is in this heat map, where this is the stimulation from -5 to 0 seconds, and you can see the train number in these 12 minutes. And you can just appreciate, what starts to be negative here becomes positive over time, and this off response changes quite a bit. Another region you can look at shows a slightly different effect. What's more prominent here is this off response. What was this sort of slow but broad off response becomes really sharp and really strong. So there's an evolution of how the brain responds as you apply these trains repetitively. And our goal right now is to basically figure out what's going on during the stimulation and how that relates to the changes, these are our CCPs, before and after the stimulation. Because if we can figure out what that transfer function is between what's going on during versus the long-term change, then we can maximize what's going on during. And we think we have some ideas as to why that is.
A question. So
Sure.
this is short-term plasticity, right? Does that translate to long-term?
Yeah, and what short-term is and what long-term is, it depends who you ask. These changes were recorded up to about 10 minutes after the stimulation, whereas these are definitely short-term during the stimulation. So you're right, how those 10-minute changes affects over an hour, and how when we apply daily treatment, how those build up, that's an open question. And how important, the 10-minute changes are, we don't really know, but we need to measure it to figure that out. The last idea here is closing the loop. So most TMS is open loop. You apply a fixed stimulation pattern for 4 to 6 weeks, and you ask, do they get better or not? A closed loop approach would start with that fixed pattern, but because we can measure EEG changes, we can monitor that activity, and based on how that activity changes, we can adapt the stimulation pattern. In this project, we're focusing on this P30, based on the previous data that I showed you in the randomized clinical trial and the intracranial approach. The idea that if we can maximize that P30 change using this closed loop approach, maybe we can get a better clinical outcome. Right? It's an open question. But the bottom line is we have one day where we'll perform this stimulation mapping day. where we vary all the different stimulation parameters that we can in TMS, and there's a lot of different parameters. Based on all these parameters, we can come up with a map of P30 changes compared to the input, frequency, duration, power. We can throw this into a machine learning model and essentially have it spit out what the optimal solution is that will maximize that P30 change. We can then test in a crossover design how your open loop 10 hertz stimulation, how much that suppresses the P30 in that individual. We can compare that to our open loop but optimal solution based on that individual, and also compare that to a closed loop approach where we start with that optimal, but then every single time we can actually update the feature weights and try to maximize that change. So that's my hope, is that we go from a sort of first generation, relatively one-size-fits-all brain stimulation treatment to a second generation that relies on objective biomarkers and real-time monitoring to personalize this approach and individualize these treatments. I want to thank everyone involved. Obviously, this was a group approach. All the TMS EEG work was done in Amit Etkin's lab in close collaboration with Wei Wu, and all of the ECOG work was done in Ash Mehta's lab in close collaboration with Danny Wang. Thank you.
So thank you. If people have questions, I have the microphone.
A couple basic questions.
Please.
So, all of this that you showed was with prefrontal cortex?
With what?
All of what you showed is prefrontal cortex?
Yeah.
What's the research or evidence of, why, is it other regions been ruled out for most psychiatric disease, or is there, what's the rationale to limit to one region?
The rationale is that's the treatment that's being used right now,
Okay.
clinically, that's been FDA approved for a long time, is
Okay.
that's treatment site is your left dorsolateral prefrontal cortex. The rationale behind Mark George and Alvaro Pascal-Leon basically starting this idea is that people saw that when you had a stroke in the prefrontal cortex on the left side, people would often get depressed.
Okay.
And so they tried the stimulation, which is normally done in motor cortex because that's the only way you could look at physiology. It was a research tool before it was a clinical tool. They tried that in the left prefrontal cortex, and that was the first place they tried. The 5 days a week is because Mark's wife wouldn't allow him to do 7 days a week. The 10 hertz is because you can't go higher and
Right,
you
sure.
would induce
Okay.
a seizure.
Okay.
So a lot of these are old, parameters that were tried once, and we don't know how to change them because the only way to measure it is 6 weeks later in a randomized clinical trial, which is really expensive. And looking active versus active, you're probably not going to show much separation. But by using sort of target engagement and neurophysiological tools to measure it, we can sort of get at these questions a little bit better, I think.
And another quick question is on the spatial aspect of the TMS. How does it, do you have some sense for what the spatial region is that's impacted, or and how that compares to, say, an EEG or the spatial region that you're stimulating it with the IEEG?
Yeah, we have an idea, and every TMS coil is different. There's actually a really nice paper by Holly Lisenby that basically took all these different coil geometries and look at electrical field modeling and saying how much would they penetrate. The figure of 8 coils that are usually used with MagVenture and those sorts of things is thought to be a focality of about 1 to 2 centimeters on the cortical surface, which is actually the separation in these ECOG electrodes. So we electrically stimulate between 2 electrodes that are about 1 centimeter different, apart from each other. So we think we're probably stimulating in a very different way. But the amount of tissue that we may be activating could be similar. Other coils, like the deep TMS coil, Brainsway coil, there's a distance and focality trade-off. And so the more you go deeper into the brain, the more swath of cortex you're going to hit on the way. And so the Brainsway coil gets deeper, but it's much less focal. So it's much more than 1 to 2 centimeters on the cortical surface. It's more like a few centimeters or several.
Can you comment a little bit more on this link between Severity and GABAergic response? Are there any evidences showing that, for example, if you use any other, let's say, pharmaceutical method to inhibit GABA, does the Severity changes?
Yeah, there actually is, and there's a couple. There's a group. Last name is Promoli, but they do a lot of TMS EEG experiments with pharmacology and using certain GABAergic A or GABAergic B antagonists or agonists. They can look at how the TEP changes, and we got this because the P30, when you gave a GABA A antagonist, we got an increase in the P30. Maybe that's vice versa, but it seemed to be they found a link between this GABAergic agent and the P30. It's not super well worked out, and 30 milliseconds, maybe that transition period, we think 5 milliseconds out, you're probably getting some excitatory drive, and then the slow wave is pretty clear and pretty well worked out that that's GABAergic. And that's true with interictal discharges in epilepsy. When you have a spike, there's a burst of action potentials and then a silent period. In animal studies, if you're 1 synapse away and you give a stimulation, you see spikes and then a silent period. But where that silent period starts and what that is exactly is not that clear. So some of that is hand waving. I also think the P30 is something that in the large-scale biomarker study that we're doing, I think some of these other potentials will come out. And it's just the signal to noise later on in the N100 and P200. There's a mix of auditory evoked potential, somatosensory evoked potential. So the TMS, only some of what's getting in is contributing to that N100, P200. There's also a lot of other noise. And so the P30 may be a little bit higher signal to noise than those other potentials. But the bottom line is I think it may all be the same wave, but it's not super clear.
So just 1 centimeter, huh? That's interesting. And is it the current is perpendicular to or just goes in the direction of the coil? So how it seems that the frontal lobe is so vast. How are you stimulating more or less the same place, person to person and week to week?
Yeah, it's a good question. And the 1 centimeter, I think, is the way they calculate that was there was a 50% drop off in the signal within those 1 centimeters. You're still stimulating outside of that too, and is a spherical way. So how are we stimulating that area?
How do you target?
How do we focus it?
Yeah.
So in the research realm, if you bring the subject into the lab, you're using neuronavigation efforts. So you're getting that patient's MRI, and you're trying to hit the dorsolateral prefrontal cortex. In clinical terms, there's a couple different ways that you do it. And in the olden days, you would hit motor cortex, find that motor twitch, and then go 5 centimeters anterior to it on the skull. Whether that hits it, how much of it hits it is unclear, and they actually changed that to 6 centimeters because they realized a lot of those patients would not get dorsolateral prefrontal cortex activation. There's something called the beam F3 method, which essentially hits F3 on your 1020 system on your electrode, which usually is around the dorsolateral prefrontal cortex. But how specific you need to get is unclear because it's not that specific, 1 to 2 to 3 centimeters. But week by week, they have caps that they basically mark that are specific to that subject. So I think there's some consistency week to week. It's just a matter of are we hitting that place in the beginning and then throughout.
For the subdural grids, it looked like you were stimulating through the ECOG array.
Yes.
Did you get a lot of artifact? It looks like, I think you get a lot of stray current from the TMS going through that array.
We do. It depends how you stimulate. So we have grids and strips, and then we also have depth electrodes that go into the tissue. So the grids and strips, when you stimulate that, you do get volume conduction through the CSF, and you get a lot of artifact within the first 10 milliseconds. We usually remove those first 10 milliseconds, but you can see pretty clear signal within 20 milliseconds or so. It's a lot less cleaning that occurs than TMS and scalp EEG measurement, but there's still noise, there's still artifact.
And how many single pulses do you usually have to obtain those before 30 information?
So it depends on the experiment and depends on how clean the signal we want. Intracranially, when we have some time, we'll pulse up to 400 times to get a really clean signal, even though the signal to noise is much higher than extracranially. So we really only need a few to get a pretty good signal. In the lab, we do 200 single pulses, mostly because we actually throw out up to 50 of those based on the noise that comes with it. In the clinic, we do 100, just a matter of time that we have. And so there's a trade-off of how much extra treatment time it's causing by doing this research tool in the clinic and how good a signal we want, right? So we want more pulses. As long as it's just separated out by more than 2 seconds, you're not going to induce plasticity. But it's just a matter of timing.
It's 100 before and after treatment, yeah?
That's what we do. We started with 60 and we realized it wasn't really sufficient, especially if you throw out 30% of bad trials. But you get a pretty consistent signal if you do 100. One in the back.
When you say that this is going into the clinic, who is it that administers this? Is it a psychiatrist, a neurologist? Is it a technician? And do you wait for people to fail out of a number of drugs before they would enter into doing this, or do you do it at the same time as drug treatment?
So you're talking about clinical TMS, not the research part of it.
Correct.
So clinical TMS, there's usually a TMS center in most hospitals at this point, and also in private practices. So it's FDA approved for depression if you failed more than 1 antidepressants. So it really depends on the hospital system and where you are in terms of where you get the referrals from either primary care or a psychiatrist. But in general, you're doing that treatment after they fail, usually 3 or 4 medications, and before something like ECT, or there's an ECT consideration, but they don't want to deal with general anesthesia or the memory side effects, and so they choose TMS. It's also a cost issue. Insurance has just started covering a lot of TMS, but it used to be out of pocket, and it used to be quite expensive. And then there's an access issue, as you come in every single day for 40 minutes for 4 to 6 weeks, which a lot of people can't do. People are working on trying to decrease the number of overall time and put multiple treatments in a single day. So they'll do up to 10 treatments in a day, so you can actually walk out of there after 4 days. And when you do Theta Burst, instead of a 40-minute treatment, you can decrease that to a 3-minute treatment. So you can imagine it's almost like a surgical procedure if you could, in 2 or 3 days, right, fly in and leave after those 2 or 3 days and have a whole treatment of our TMS. How sustained that response will be is another question, is if you just sort of let them go, are they going to relapse, or do they need to come in for some maintenance treatments? But
Are there any efforts to miniaturize the TMS apparatus to make that a little more accessible for patients?
there are a lot. I'm not fully aware of all of them. There's one that's actually approved for migraines that applies single pulse TMS that you can actually take home and put in your pocketbook almost. You can look it up. It's called eNeuro. But if you do repetitive TMS, the coil is going to heat up. So you need some sort of cooling system, which allows it to be not that mobile. People are trying to put smaller magnets, and many of them, across the brain in some like helmet, where you can essentially adjust the magnetic field that you would potentially, the accumulation of many of those magnets could get into the brain and hit the spot that you want. So it's partly a physics question, partly a cost question, but people are thinking about how do we get this take home, how do we make it easier, how do we make it more adjustable, those sorts of things.
There's a question here.
There's another world of electrical brain stimulation which doesn't use the magnetic pulses, but it uses a DC or AC current applied for some minutes or hours. Is there any intersection between these two worlds of research and treatment?
Yeah, I mean, people are thinking about how do we apply direct current stimulation or alternating current stimulation for depression and other disorders. There was actually a New England Journal of Medicine paper that came out earlier this year that basically showed that there was no effect of direct current stimulation compared to placebo. And it was a big paper that came out. And so from a research point of view, I'm a little bit less interested just because we don't really know where in the brain it's going. It's much less focal than TMS. It costs $10 to make. It's basically a battery, and so if we could do it, it would be amazing if it was effective. But from a research point of view, it's less interesting. There are other tools like focus ultrasound and other ways to sort of target how do we get millimeter precision in the brain, and so this field is evolving. I think using this tool of pairing EEG with that neuromodulation tool is something that will be used, whether it's not TMS or whether it's ultrasound and this biomarker monitoring platform and tool. An idea can be used for any of these approaches.
Speaking of how to use this tool, so you've talked a lot about depression and depression symptoms or whatever. So sort of two-part question. One is there a particular symptom of depression, anhedonia, or any other sort of broken down part of depression symptoms that seems to respond most to TMS? And then a second question is, what about cognitive, could you, have you, or can you, or how do you envision that you could use this to interrogate kind of the effect of TMS on information processing, not necessarily emotion-related circuits?
Mm-hmm. No, it's a good question. For depression, there's a couple different reasons why people chose that dorsolateral prefrontal cortex besides the stroke information. But the bottom line is that we think we're strengthening sort of cognitive control as a whole, that your central executive network, that you're just increasing the ability to make those decisions. And that's why it seems to be an effective tool across a lot of different disorders. So it's not something specific to depression per se. That's one of the ideas. The other idea is that the dorsolateral prefrontal cortex is anti-correlated or negatively correlated with the subgenual cortex, which has been implicated in depression. So if you can turn up one region, does that turn down the other region? Second question was about using cognition to assess the effects.
Cognition as an outcome, so instead of improving symptoms of depression or PTSD,
Mm-hmm.
actually enhancing cognition, for example, or using it to just as a tool to interrogate what brain systems relate to what. What's a more sophisticated tool potentially than just fMRI,
Mm-hmm.
as you mentioned, which is correlative.
No, it's a great question, and it's one that, if we think we're hitting this cognitive control system, why aren't we using a behavioral measure to actually look at that outcome as opposed to the depressive symptoms and those sorts of things? I think we should be. The question is what tasks to use, and is there consistency across studies to do so? And so we've struggled with this for a while, as we have these self-reports of depression, anxiety, and quality of life. We've started implemented and tried to implement an iPad-based sort of neurocognitive assessment of DLPFC. How do we do working memory and some other cognitive tasks in, say, 5 or 6 minutes that we can put in the waiting room that we can measure weekly? I'd be interested in hear what you thought, but everyone sort of has a different opinion about which task, and it's just not super clear. So we'll get there, and I think we definitely need to incorporate that in. Even things like, how do we use a task to activate that brain network while we're doing TMS, right? We're doing this at rest, and it's a lot of animal literature that shows if you don't activate those neurons, you're not going to get as much of an effect when you do the stimulation. So can they have an iPad in the clinic, activate them, then stimulate, and then you can test those sorts of questions very easily. But yeah, we're thinking about it.
Maybe one last question.
So, is there any relationship between the severity of depression and the degree to which you can affect it? I mean, I would imagine, especially when you talk about the metaplasticity aspect, you're trying to shift a threshold. So if that threshold is really relevant, then the more severe the symptoms, perhaps the further away it is and the more effect you can have. So I don't know if there's some
yeah, I think it's
evidence
not
to that.
super well worked out. I think what we know, we're already enrolling a patient population that is severely depressed and is medication resistant. It's pretty well known that the placebo effect works better for those that have more intact brain circuitry, that are less severely depressed. And we see that with TMS too, that we see a stronger effect in those that are less severely depressed. So if they're
That's sort of the opposite in a way.
yeah, I've heard the hypothesis from both sides, right? Your circuitry is more abnormal, so therefore TMS should be able to fix it, and also it's less abnormal, so that should be able to more easily bounce back. So, you know, if you take something like seizures, right, the more you have seizures, the more ingrained that network is to be abnormal and the harder to fix it is. So if you can take that approach, or the more severe, you should be able to bring it back. But I don't think there's great evidence suggesting one versus the other.
Well, Dr. Keller, thank you very much. I think you can tell from the lively discussion that you've stirred a lot of interest, stimulated a lot of interest. So as chair of the department, I want to thank you very much for this presentation. We have a small tradition in psychiatry that if we like what you say, we present you with this UC San Diego School of Medicine, Department of Psychiatry cap. In your case, we have worked closely with our colleagues in engineering and computer sciences to install very tiny sensors within this cap. You can't even see them, but if you pair the cap with your smartphone, you'll be able to track your stimuli.
Thank you.
So there you go. Thank you very much.
Thank you.